Thank you for viewing this presentation. This module discusses major rectal complications following treatment of prostate cancer. The treatments for prostate cancer are usually very well tolerated. Major complications after treatment are quite rare. However, they do occur at times. This module will outline some of the signs and symptoms of rectal complications, including ulcers and fistulas. It will explore how these complications can be caused by radiation treatment, and some of the tests or treatments that a physician may recommend should a complication occur. A rectal ulcer is a chronic sore or disruption within the inner lining of the rectum. The ulcer can involve some or all of the layers of the rectal wall. Some causes of rectal ulcers include damage from trauma, radiation, or other medical conditions like Crohn's disease. A fistula is an abnormal connection or tract between two organs, or an organ and the skin. One example is an abnormal connection between the bladder and the rectum. The exact process beginning at tissue damage to the development of a major complication is not fully understood. Major complications are rare, and the majority of patients undergoing treatments like surgery or radiation never develop major problems. Development of a major complication likely represents a combined contribution from exposure to treatment, environmental factors, and genetics. A proposed mechanism of radiation-induced injury is that radiation can cause damage to cells and the small blood vessels feeding the surrounding tissue. In the bowels, tissues surrounding the damaged area experience decreased blood flow, starving them of nutrients like oxygen. Further, waste products can start to accumulate, causing additional toxicity. The resulting condition is called ischemia. In response to the damage, the tissue can become inflamed as the immune system responds. The affected tissue may begin to thicken and scar, leading to a condition called fibrosis. The ischemia, when combined with inflammation, can cause further damage to remaining cells within the bowel. If the damage is too severe, the tissue can die. Without live, viable cells to make up the rectal walls, an ulcer can form. These ulcers can progress to form a fistula if they do not heal on their own. Following radiation, bowel ulcers are rare, but when they do occur, they are most often located in the rectum. This is likely because the rectal tissue is located near the prostate and is exposed to a higher amount of radiation. These ulcers can occur months to years after radiation therapy. Some symptoms of ulcers include deep-seated pain in the rectal area, bleeding from the rectum, mucus discharge, and a sensation that the rectum isn't empty even after bowel movements. This sensation is called tenesmus. Fistulas are a more severe case of disruption of the rectal wall. In addition to the symptoms of an ulcer, the abnormal tract they form can cause additional symptoms. Depending on where the fistula forms, this could include passage of stool out through the skin, passing urine out of the rectum, passing air or stool with the urine, or repeated bladder or urinary tract infections. Patients who experience bowel complications following treatment for prostate cancer should speak to their healthcare team. The first step usually includes a detailed medical history to explore these symptoms. The team may perform a careful physical examination. If warranted, a camera examination will be ordered. This could include a colonoscopy, which is an examination of the whole colon, or a proctoscopy, which focuses on the rectum. In order to avoid causing further irritation or damage, a biopsy or sample of the ulcer should be avoided unless discussed with the whole medical team, including the surgeon or gastroenterologist and the oncologist. For more information, there is a separate detailed module on colonoscopy. There may be additional tests ordered as well, such as CT scans or blood work. Bowel complications can occur following all types of prostate cancer treatment, such as brachytherapy, external beam radiation therapy, prostatectomy, cryotherapy, and high-intensity focused ultrasound. Following brachytherapy, major rectal complications are very rare. Ulcers occur in 0.5 to 1.5%. approximately 1 in 65 to 1 in 200. They are even more rare, occurring in less than 0.1% or less than 1 in 1,000 of cases following external beam radiotherapy or prostatectomy. Fistulas are also rare following brachytherapy and prostatectomy in the range of 0.2 to 1% at most, or 1 in 500 to 1 in 100. They are extremely rare following external beam radiotherapy, much less than 0.1% or less than 1 in 1,000. The fact that these major complications are so rare makes it difficult to say with certainty what things contribute to their formation. Some medical studies have suggested a link between inflammatory bowel diseases like Crohn's or ulcerative colitis and ulcers. Ulcers are a large part of both of these diseases, so it isn't clear if radiation makes them worse or if it only helps uncover ulcers that would have occurred anyway. Physical trauma to the rectum has also been associated with ulcers. In some case reports, damage from suppositories or direct trauma has led to an ulcer. This could be because the radiated tissue isn't able to heal itself. Similarly, taking a sample or biopsy of the rectum could lead to damage which isn't able to heal. Before having a rectal biopsy done during a colonoscopy, it is important to have a discussion of the risks and benefits given the possible increased risk of major complications. Occasionally, invasive treatments or investigations are needed in the pelvic area where radiation has been delivered. Some studies have suggested an association between these procedures and rectal ulcers or fistulas. Some examples of procedures that may be associated with an increased risk of bowel complications include salvage prostatectomy, which is a radical prostatectomy following radiation, transurethral resection of the prostate for difficulties urinating, prostate biopsies, or argon plasma coagulation of the rectum for bleeding. Because they may have an inflammatory component, many of the treatments are similar to those used for radiation proctitis. This topic is more thoroughly described in a separate module. Rectal ulcers can often respond to non-surgical treatments, including sucralfate or 5-ASA, steroids, or other anti-inflammatories. Hyperbaric oxygen is sometimes used if conservative measures fail. This is delivered in a specialized chamber where patients breathe 100% oxygen under increased atmospheric pressure. This may improve the amount of oxygen delivered to damaged tissues, thus assisting in their repair. Unlike ulcers, the abnormal tracts from fistulas are unlikely to heal with non-surgical management alone. Surgery is usually required to fix a fistula. Severe ulcers that do not heal with conservative measures and medications may also require surgery. Repairing a fistula or severe ulcer begins with diversion. During this step, the flow of stool is redirected by the use of a colostomy. The stool exits into a bag which is attached to the outside of the abdominal wall. This allows the affected bowel to rest and prevents further irritation or damage by continuous exposure to fecal matter. Urine is also diverted away from the fistula. This can be done by the use of a catheter. Catheters may be through the urethra or through the abdominal wall, called a suprapubic catheter. The bowel and bladder rest from diversion is often enough to allow many ulcers to heal. However, fistulas which have already formed are unlikely to close on their own. Following diversion, the second phase is a surgical repair. First, the abnormal communication, the fistula tract, is removed and the rectum and urinary tract are separated. The holes in these structures are then closed with stitches, or sometimes with a graft of tissue from another part of the body. Tissue flaps from nearby are then laid in between the rectum and urinary tract to ensure that they cannot form a new fistula tract as they heal. These transplanted tissue flaps, such as muscles or fatty structures, are inserted with their own blood vessel supply to ensure that they survive and remain viable. The image here shows a relatively simple repair. These images show a more complex repair requiring a graft of tissue to help cover the hole in the urinary tract and a flap of muscle from the inner thigh to fill the space between the rectum and urethra. Once the flaps have been incorporated, the tissues are given time to heal. Once healed, the diverted stool pathway is reconnected and the urinary catheter is removed. The process of repairing a fistula that forms following radiation therapy or prostatectomy is very similar. The main difference is that fistulas developing following radiation therapy are somewhat harder to repair because of the fibrosis and the poor healing ability of radiated tissues. Despite this, up to 60% of patients with fistulas following radiation have a successful repair. The exact causes of these major complications have not been determined. However, avoiding the risk factors associated with them could reduce the possibility of developing complications later on. There have been a number of medical studies which indicate an association between rectal biopsies and ulcers or fistulas following radiation therapy. If you are a patient who is getting a colonoscopy or proctoscopy and have had prior radiation therapy, please ask the physician performing the procedure to contact your oncologist before performing any rectal biopsies. These biopsies should generally be avoided if possible, and the pros and cons of having the biopsy done should be carefully weighed. Ulcers and fistulas are very rare, and therefore not everyone will be familiar with their symptoms. If you have developed any of the symptoms described in this module following treatment for prostate cancer, you should discuss them with your healthcare team. In this module, we have reviewed the major rectal complications of ulcers and fistulas that can result following treatment for prostate cancer. These complications are rare, but can have a significant effect on quality of life. This module explored some of the investigations and treatments used to address these complications. Treatments can involve many different specialists, including oncologists, urologists, and gastroenterologists. This highlights the importance of input from all the members of a multidisciplinary cancer care team. Thank you again for viewing this educational program.